And again, my apologies, but my sitter just emailed me, and by the time I looked at it, well, she should have called me last night instead of 6 o'clock in the morning, but that's neither here nor there. Whatever it is, you guys are good. We're here. There's a recording going on, and this is now week 8. So we're on topic 8. So what is due today, May 3? It is all that, yep, good on you. See, but here's my question. Where is everyone else? Is everyone else just late and just, and remember, gang, for you future nurses, that's it's not only a pet peeve when you think about it. Going forward, don't, that's what I'm trying to say. Don't be late on anything, especially when you're in the ward. There's something called out of post. Out of post, you get demerits. Like, for example, in medical school, if you're not where you're supposed to be, even if you're in the building, you get 7 days demerit. That's 56 hours then you owe the institution. And just imagine if you're getting paid, that means you get docked 56 hours. So it makes everyone be early, not on time, but just be early. So good on you, those of you who saw the message, but also good on you, those of you who trekked it and made it in. So of course, what's due today? Musculoskeletal medical language laboratory. I'm gonna go look at that later. Most of you have seen that I didn't grade week 7 yet, because I give everyone the benefit of the doubt. I try to look at it later today. But what are we doing today? We are doing week 8, and week 10 is our final exam. So we're close. We just have this week and then next week, and then have a quick review, and then you have your final written exam. And as of right now, well, we'll see. Look at your announcements. I'm going because if if my sitter, what she said is true, she's going to be out for 2 weeks because apparently her child or someone in her family has COVID, so she needs to get tested, or she can't be in my house. And also the service we hire, I know for a fact won't let her into the house. And so let's see. And it's okay because we're a didactic class. There's no laboratories to miss. So we could still do everything online. But as of today, we are coming in week 9 and we're coming in week 10. So look out for your announcements, because if I can't resolve this thing today or tomorrow, we're just going to go full online for this particular class. So what are we doing? And that's my public service announcement for the upcoming weeks. What are we doing today? Reproductive system. And what's due next week, the 10th, before 9 a.m. Your critical listening exercises, response exercises, and of course your quiz. And the discussion forum for this week is the same as always. Let's write it down. Discussion 8 would be create a quiz based on the reproductive cases in the back of the current chapter. Your submission should be a 5-item quiz. That means it should have 5 questions based solely on the reproductive case. Oops, don't know how to spell. Chosen. Okay, and we're going to go over that. This is due May 10, 2021, 9 a.m. along with everything else. Right, same protocols stand. Let's make this a little bit bigger for those of us who have vision problems, including myself. So that's all due next week. So let's go back and go to our medical language laboratory. Then we find our book. And then we go to the reproductive chapter. Now, reproductive, the people in our neighborhood is twofold. If you were a male, I think we mentioned this before on another lecture, and you have reproduction problems, right? You need to go visit the urologist. And if you're female, you need to go visit the gynecologist. Those are the two main if you have reproduction issues, like you can't bear children for whatever reason. For example, my niece and my nephew, they've been married more than a year. They've been trying for more than a year, and they went to a specialist. Now, my nephew says that the one specialist saw both of them, and that person is a urogynecologist. So let's write down this summary just so we're all on the same page. So gynecologist will see any female patient with reproductive issues and/or female anatomy and physiology issues. A urologist, that's a little tricky, they can see only male reproductive issues, but they can see both male and female for any problem with the urinary tract. But what my nephew saw was a urogynecologist who can see both male and female partners for any reproductive issues. And this person might be labeled as a fertility specialist. Alrighty, doesn't that look like a beautiful exam question? Hint, hint. On who's who do you send to what department? Now, once mommy is pregnant, then they go to the obstetrician. Obstetrics. Okay. Okay, that's OB. So when you see OB-GYN, that's one department, but they're divided into two teams. One is for obstetrics and the other one is for gynecology. And they call OB-GYN or OB-GYN. That's the slang and abbreviation for it. Okay, so that's urology. Now, urology deals with the ureters, urinary bladder, and urethra of either male or female. But it is the nephrologist that we already learned. They're the ones that deal solely with the kidneys. Here's, of course, the female reproductive tract. It's nice for anatomy and physiology, but we are interested in the medical terminology. But these pictures are very, very nice. And you can see urinary bladder. This is your urethra. This is your uterus, also known to our patients as the mommy's womb. This is where there's going to be implantation of baby here in the upper anterior corpus or body of your uterus here. And here's your cervix leading to your vaginal canal and your introitus, which is the opening here. And of course, your anus is the opening, but it is the rectum that's the tube. Same thing with the vaginal canal. The vagina is the muscular tube that leads towards the uterus. But the opening is your introitus, which is something different than the. So when we typically speak about the vaginal canal, we're more interested than the pathway than the just the mere opening. So let's look at some of these words that may come up on a case or may be related to a case. Amnio. When you're a baby, you're covered in two sacks or two coverings. and your amnion or the amniotic sac is one of them. And if I puncture it surgically and without puncturing the baby, I can get amniotic fluid, which can help me diagnose any genetic and biochemical problems. Now, we don't do it so that we can abort the baby. We do it so we can prepare mommy on what's to come. Okay. Cervicitis, remember the cervix we just saw, inflammation or infection. And remember the vaginal canal. So when we perform a colposcopy with a colposcope, right? And we do it so we can do the pap smear. So the pap smear is when we get scrapings from your cervix. You have your external os, which is this part here, internal os, which is this part here, and the scraping of the vaginal canal. That's why when you look at the pap smear stick, or I don't know what you would call it, probe, or I forgot what you call it. I call it a brush because that's what it really is. If you take a look at it, see this here? You see how there's like one part here, and then it'll also scrape the sides as well. And this is a speculum, and this is the equipment you put in here. So it can get internal, external, and also cells from your vaginal canal. And then you put it in this bottle here, and then break off the stick, and then submit that to the laboratory. And this is fixation fluid, and so that the cells don't, we don't lose the cells. And that is a pap smear, also known as a Papa-Nicolau smear. Where's the whole word? Here. And it's a lovely screening test for cervical cancer. Okay, where is it? Papa-Nicolau or pap smear. Here it is, right here. Vaginocele, herniation into the vagina, also known as a colpocele. So if, let's say, mommy had, like, I don't know, 8 kids back to back to back, you're going to have loosening of this. Here's the perineum, which is the area in between the vagina and the anus. And also you could see here, there's muscles here that form what they call the pelvic floor. When this gets all weak, you can have a herniation or a prolapse of the vagina. That means this tube will now slide out, and that's not good. Same thing with the rectum. You could also have rectal prolapse. All of these muscles here are part of the pelvic floor that hold these tubes in place, and all of these tubes can prolapse or can herniate or stick out, and that's not a good thing. And that's called the vaginocele, also known as the colpocele. So we schedule a colposcopy, and I utilize a colposcope. Galactorrhea is abnormal discharge or excessive discharge of flow of milk. Lactogen is the chemical or the hormone that will signal your mammary glands to produce milk. Lacto meaning milk, gen meaning forming or creation of. So a lactogen, an example would be prolactin, and that's your natural hormone. So if you're of childbearing age and you have a baby, the prolactin gets increased, and then you'll have the milk let down reflex. Gynecologist, we already talked about. Gyne means female or woman. So gynecologist is expert at female and women issues, which also include breast cancer and breast problems. Okay, because remember, always have your self-breast examination monthly, please. Very important. Just like your, if you're of childbearing age 25 to 45, have regular pap smears. 30 years ago, people were dying, women were dying of cervical cancer because by the time they get diagnosed, it will already be end stage. Nowadays, we get it really early. And then if we get cancers early, we can treat them early and deal with them early. Hysterectomy, that is a surgery where I'm removing the uterus for whatever reason. We could do it vaginal route through the uterus and vagina. Mammogram, that's another screening thing, ladies, that you should do regularly, especially if you have history of breast cancer in your family. And if we do remove, we do a mammectomy, we also must perform a mastopexy and mastoplasty to put the breast back together. So mastopexy, I have to perform surgical fixation of the breast or the breast material that I'm going to put back, like let's say, for example, an implant. And mammoplasty is repair, surgical repair of the breast tissue. If you may recall, Angelina Jolie had because she hit up all the hormone markers for breast cancer, and her mother had it. Multiple family members had it. So years ago, she did a bilateral mammectomy, removed both breasts, but you could see, right? She had also mammoplasty done. And when we do mammoplasty, we also have to perform a mastopexy to make sure that all that material stays in place. Menstruation, mens or menses actually means monthly. So menorrhagia, bursting forth, that's an abnormal menstrual cycle. That means my patient is hemorrhaging an excessive amount of menstrual flow. Endometritis, meter, M-E-T-R, that means your uterus. And we already also saw another word for uterus, hyster. Ladies, be careful if someone calls you hysterical. It's a little bit on the sexist side, because when you think about what does the word hysterical mean, right? It means what? Crazy or funny, right? Well, it could be used quite wrongly, if that's a word, because look at the word hyster. It means the only person could get crazy is somebody with a uterus. So be careful in the context of which someone calls you that. My mother won a case years ago. She had a colleague who didn't understand, well, that among other things he said to her. So ladies, you are in healthcare, and healthcare, we do things the right way and we talk to each other the right way. And calling a woman hysterical, I don't think that's it, if you look at the true definition of the word. So meter and hyster, that looks like a beautiful both A and B question. So endometritis. So I'm looking at inflammation or infection, endo, inside the womb. If I had perimetritis, it would be outside or surrounding. If I had myometritis, it would be in the middle or in the muscular section. So again, you could see how you change the prefix, you can change totally the meaning of the word. Prenatal, postnatal, and perinatal. The biggest prevention of any perinatal issues or the day of the birth problems is prenatal care. Fortunately and unfortunately, I worked for a state hospital. That's why I delivered so many babies, because a lot of the patients did not have very good prenatal care. And we're living here in the United States of America with the best neonatal in the country. And money or no money, there's no excuse not to have prenatal care. There's a lot of free care for those who apply. But most people, they don't, especially the younger patients. Now, postnatal care is also equally important. So, the wound healing, and also when I do my postnatal care, when I was practicing, I want to know how mommy's feeling, because right now, like today, being a parent is not fun. It's currently not being fun, balancing all these things at once. And those of you who are parents know this. So especially in a primogravid mommy, and we're going to talk about that term in a moment, it's rough, and you could get the baby blues, and you could get postnatal depression quite easily. And I've seen it firsthand. My wife on her third child had it really bad. We had to call in family members, and she couldn't get out of bed, wasn't motivated to do things. It's not just crying a lot. It's remember, um, uh, um, um, depression is it's easy to say, but it's a very, very difficult thing to explain to people who have not experienced it. 004, ovaries. So you could have an oophoroma or a tumor in your ovaries, and it could cause it twisting, and then you could get something called ovariorexis, because if it twists around, it could rupture, and that's not good. Causes a lot of pain, and the differential diagnosis for it would be appendicitis. So it's going to hurt that bad. Your perineum, we already talked about, the area in between your vaginal introitus and your anus. And we have to cut a little bit, especially on the first-time mommies, or if the baby's too big and they're delivering per vagina. Salpingo, salpingectomy. I'm removing the fallopian tubes, which now brings me to a 25-cent word, which you may see, called a tabasel. Let's break this down. It's a total abdominal hysterectomy with bilateral salpingo oophorectomy. Now that's a 25-cent word, but we now know better. We break it down. Total abdominal hysterectomy. That means my opening incision will be where? Abdomen. What am I doing through that abdomen? I am removing the uterus. So I removed one uterus. Then I did a bilateral salpingo oophorectomy. So bi meaning two, later, two sides. So I have a left fallopian tube and a right fallopian tube. So I removed what? Two fallopian tubes, both left and right. What else did I do? I also removed two. I won't. I also removed two ovaries, both left and right. So a tabasel, or total abdominal hysterectomy with bilateral salpingo oophorectomy. Try to say that 5 times fast. It's easier just to call it a tabasel or TAHBSO. I removed one uterus, two fallopian tubes, and two ovaries. And that's some serious, serious stuff. There's going to be serious health considerations and also post-operative care for this patient. It's going to be at least 2 to 3 weeks recovery time. And since I removed your ovaries, there goes any hormones. So what must I do? I have to also provide hormone replacement therapy for the rest of your life. Because if I don't, well, there's pros and cons to it, and we're not going to get into it here. But if I don't, my patient's going to now post-operatively start experiencing postmenopausal symptoms, because the ovaries will no longer be there and kicking out any hormones like estrogen and progesterone. Now, that's tabasel, so that's nice. Vulvopathy, and the vulva is the outer introitus and the outer part of the vaginal canal. Episiotomy, that's the incision of that perineum that we talk about. It's best just to show you a picture. For those of you who had children, you probably know what this is. So when I have baby, I have to cut. So see, there's crowning, baby's coming, right? So me, I usually do it around 7 o'clock, 2 to 3 centimeter cut. I use Mayo straight scissors and I cut that part right there so that baby can go out, right? I don't like midline because it heads right towards the anus, and that's not a good thing. I like the 7 o'clock. And then of course we have to, right? We have to sew it all up. You do a internal mattress here and then a running stitch on the top. Okay. So that's what episiotomy is. Tomy, cut. What am I cutting? I'm cutting that section of the perineum at the 7 o'clock position. Menarche, that's the first time you had your period. And when it starts going away, that's considered menopause. Now let's look at this gravida and para. But let me talk about these other things first, and then we're going to talk about this G and P. Salpinx, hematosalpinx, salpingo, we already know that. So hematosalpinx, there's blood in your fallopian tubes. That's not a good thing. Dystocia, dys means abnormal or painful. Now, those of you ladies who had childbirth were like, well, Dr. Garais, that's a stupid word. Painful or difficult labor. No, mommy knows that mommy can tell you the difference between normal labor and what feels wrong. Every time, even a primogravid mommy or a first-time mommy says to me, Doc, I don't feel good. Something bad. Something feels really bad. I listen, and that's why out of the 68 children I delivered, I only delivered 2 stillbirths, and both of them had no prenatal care, and one of them was telling me something's going to go down, and she knew it, and of course the lack of prenatal care is also hard. Retroversion, I did 2 or 3 of those in my career. It is when the uterus retro is facing backwards. For example, if you see the uterus here, if there's a baby here, do you see even the curvature of the spine? It all facilitates baby to slide down like this way. But what happens if the uterus starts turning over here, and then this external os starts hitting this wall? Then baby has nowhere to go, and it'll be bumping into this part right here. And that is what we call retroversion. Another form of retroversion is the version or the lie of the patient is of the baby is wrong. So we actually have to go stick our hands in there, and then also apply pressure out here, and then move the baby and turn the baby. But 9 times out of 10, when we're talking about retroversion, we're talking about retroversion of the uterus. So let's jump right into this G and P. Okay. Anyone know what the telephone code is of G and P? Oh, well, I'm about to tell you. And this is just the first part. There's 4 more numbers, but let obstetrics teach you that. G stands for gravidarum. When you're gravid, it means you're pregnant. P stands for parity. That means actual delivery. Okay? A baby came out. Whether living or not, a baby actually came out. So when we have a telephone code, G0 means nulligravid. They've never been pregnant. G1, primogravid. This is the first time they're pregnant. G2 and beyond, they're multigravid. That means they've been pregnant 2 or more times. Okay. Now, P are parity. If they're nulliparous, never delivered. If they're primiparous, first time delivery, first time mommy. Primipar. Okay, I hear one of my kids awake. Oh, Jesus. All right. And of course, if they have multiple deliveries of 2 or more, they're what? Multiparous. Okay. Either many deliveries or multiple babies at once. And multiple babies at once, twins and triplets and so on, a lot of the laypersons like, oh, how cute. But for medical personnel, that's danger, danger. Human beings are not multiparous creatures, okay? We are only designed to have 1 baby at a time. So when there's more than one, do any of you guys know twins or any family members who are twins? I got triplets in my family. The first one, he was super, super healthy. The two younger ones were smaller, had health issues, and the eldest one became all three of them actually became tennis prodigies. They went to we shipped them to Florida, and the oldest one was the only one to go to the nationals. He went to college, and now he has a good career, good life, and so on. The other two quit school, joined the Marine Corps, and now went back to school, then quit school. The two younger ones now have significant mental and psychosocial issues, where the eldest one does not. And you'll see a lot of these twin studies. And if any of you guys know a twin, one of them's dominant, and you'll see them. They're not only dominant mentally, socially, and physically, right? Because when mommy only has so many nutrients, it doesn't necessarily mean that all the nutrients are going to be shared. And there's a lot of twin studies regarding that. So I could ask you, if the patient here, right? Let's have a patient here. Let's have my wife, for example. She's G5P5 patient. That means she was pregnant how many times? Well, actually, that's wrong. She had miscarriage. She was pregnant 6 times, and she delivered what? 5, right? And then I have 1 adopted, so that makes my 6. So that patient is multigravid and multiparous. How is this? My niece, she's G1P0. She's a good 25 weeks in, 25, 30 weeks in. This is the first time she's ever been pregnant, and she never delivered. Okay. So that's an example of what they call the telephone code. It looks like a beautiful clinical thing that I could put on an exam, don't you think? Hint, hint, nudge, nudge. No, you guys don't think that? I'm the only one who thinks that? Okay. And where the heck is everybody else? Miss Melania, is anyone else on campus? Are you the only one? Man, did you guys started off with like 13 of you, and now we're down to like 3? Ooh, well, welcome to health science. That's what happens. Hello, anyone hear me? You guys still there? Hello? Anyone check out? Miss Melania, anyone else on campus?
Oh, no, I just got home. I was driving.
Oh, okay. So,
Yeah.
because I hope people aren't sitting there on campus. Okay. Maybe they are, maybe they aren't. All right. But you guys are good. And again, like I stated, I will check. I will I will check the activity logs and whoever has activity for today. And also, let me look at my phone. No one called me. So maybe everyone else is on campus. Who knows? All right. Let's move on. Again, lovely, lovely pictures here. If I had a tabaso, I would remove this, 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 and this. So everything from the broad ligament on up. So this is your uterus. There's 2 fallopian tubes and 2 ovaries. Okay, so hysterectomy, of course, we're going to remove the uterus. And it could be partial, depending on what we're trying to solve. Here's D&C, a dilatation and curettage, D&C. So I dilate it using this probe. It's a metal probe, and it's got little notches in it, so I know how many centimeters in. And of course, this part here that you don't see is the speculum to open up the vaginal canal. And the first thing I do, I have to dilate the cervix. And I open it up, and then opens it up so that I can put this serrated metal spoon that has like knives on the end of it. And that scrapes the endometrium. And you can see the endometrium here. That's this pink lining right here. Then you have the myometrium, which is this level. And then the perimetrium, which is this gray stuff all the way on the around. Okay. So when I scrape that, I could use it for a biopsy and or TOP, which is termination of pregnancy. So if there's a baby in here, or fetus or whatever, I start scraping away. You guys know what happens. Then we take a vacuum and we vacuum it out. Sorry to be very graphic, but we are in healthcare. And yes, these things get done. So that's a TOP, or termination of pregnancy, also known by the layman term abortion. And guys, if you're ethical, please, if for future training don't want to be a part of it, you're allowed to say no. I always tell this story because I was failing obstetrics 2 in medical school. I remember I was in 3rd year and I was like in trouble academically, of course. And then I did like, I don't know, like a dozen of them in a row. And I thought it was mandatory. Years later, I found out that I was one of the few people who said yes, and I did it. And it didn't even give me any extra credit. I could have bowed out of it. Remember, we are an ethical an ethical service. So if something's not ethically right with you, stand up and speak up about it. And everyone's looking at me like, how many of them you did? And I'm like, I did like, I don't know, 14, 15. And it's rough because that's some really, really hard things ethically to deal with, especially if you're a semi-religious person. Here's the breast tissue, and here are the mammary glands. And here there's fat surrounding the mammary glands. And ladies, when you do your breast self-examination, make sure to check your axillary area here, because you see these axillary lymph nodes. Even if you don't feel any breast abnormalities here, if there's cancer anywhere here, these lymph nodes will be activated, and you'll feel a little bump here in your armpit. So make sure to know how to do your monthly breast self-examination, and you can look that up on YouTube. There's tons of wonderful videos here. So many times nowadays, when we do find something and we do a biopsy and we find that out that it's either benign or malignant or whatever, we know that it's cancer. What can we do? We can perform a lumpectomy. We don't have to do an entire unilateral mammectomy. I don't have to remove the entire thing always. But if it's invasive, especially if it's spread to the bone or the other lymph nodes or to your lung, that's bad news. We got to remove the whole thing. And sometimes we got to remove both. And both is bilateral. Okay, here is male. And it's similar things. You have the testes, which are just like the ovaries. They developed and moved downward here, right? And then you have the vas deferens, which will bring, the testes are the sperm production factory here, and it up the vas deferens. And then when we perform a vasectomy, this is the thing that we cut. You have the urinary bladder here, right? Going into your urethra. And this is the penis, and the head of the penis is called the glans. Of course, you have the rectum here, and it goes, and again, similar anatomy, but the development then changed. The female clitoris is the homologue, or the the similar structure on the female, and the ovaries is also homologue to our the male testes here. And you'll learn more about that in your anatomy and physiology. So all of us were, when we were babies, we all had the same parts. Well, even before we were babies, when we were prenatally in our mother's uterus around week 6 age of gestation, if you're X chromosome, you become female. If you have XY chromosome, you become male. And that will signal a whole bunch of hormones called androgens. And that will then form these things. So glans penis, balanitis, inflammation or infection of the glans penis. Gonads, of course, are any sex organs such as testes for the human male, and why am I saying human? Of course it's human. Testes for the male, and ovaries for female. And both of them have hormones and sex glands called gonadotropins that produce, that help produce and enhance your testes or ovaries in the female. Cryptorchidism. You notice that your ovaries are up here in your abdominal canal. Well, when before little boys came out to be little boys, the testes were up here, and then they started slowly moving down here and into the scrotal sac, which is right here. And they could be stuck up there in the abdominal or somewhere in between, and that's called cryptorchism. Crypt meaning hidden, orchi meaning testes. Orchiopexy. Sometimes I do an operation to bring that down. And if I have any cancer or things that I have to remove, we must perform an orchidectomy, and that's removal of one or both testes. And testicular pain is also known as testalgia. Now, you'll also notice males have a prostate gland, which is right here. You can see it. Okay, it intersects here, your ejaculatory duct and your urinary tract. That's why if you have any prostatitis or any prostatic carcinoma, it's going to mess with urination, and it's going to mess also with your ejaculatory duct, which will cause erectile dysfunction problems. So those are the two main things with BPH, or benign prostatic hypertrophy, which is not cancer. That hence the term benign. And you'll have an increased PSA, which is prostatic secretory antigen. And that means you have BPH and or cancer. So prostatitis, spelt it wrong. It's take out this E, so prostatitis. So prostatitis, and BPH is a classic form of prostatitis. Spermatocyte, that is your sperm cell. Spermicide, that's what that chemical, naloxone 9. This is my thing. It's a funny observation that I saw on Cavicide and these other, those hand sanitizers. It has naloxone 9 in it, like as if there's tons of sperm in your lab. If there's tons of sperm in your lab, that's an issue. You could have aspermia. Oh, not you, but your male patient could have aspermia. That means they have no sperm, no semen. But oligospermia, right? That means you have a low sperm count. It doesn't necessarily mean that you will be infertile. I am a classic example. I diagnosed myself with oligospermia. Then I had 2 more tests confirming it with the #1 or valedictorian graduate of Rutgers University, who's now a doctor. Well, actually, he's a nurse. He became a doctor, then he became a nurse because, I don't know, it's a long story. But my very good friend, Dr. Amory, I remember we were in second year, and I go, oh my God, I have oligospermia. I go, I don't think I can have kids. And we did the count, and he was like, no, you probably can't have kids. That's why every birthday, out of the 5 children that I have with my wife, I call Dr. Amory and go, hey, and he goes, someone should take away your MedTech license. You told me, and he reminds me, oligospermia is not aspermia, right? And remember, and it's also, I am living proof that all it takes is 1 single sperm to get there, and you will have baby. And I have babies in droves. Varicocele, that's a dilated vein, okay? And herniation and swelling. The vein isn't where it's supposed to be, and it'll cause a varicosity, okay? And also a backflow of blood. And you've seen those in varicose veins. Maybe you saw your grandma or grandpa. This happens. What do you call that? The valves in your veins fail. Typically, the valves prevent backflow, but then so that blood in the veins only goes one way. But then when these veins start to fail, and then you're going to have herniations or outpocketings here, then you got this stuff. And you get something called claudications, and it gets painful. There you go. There's a typical. And this is for people who typically are on their feet all day, every day. And when they When they get older, you get this. But you keep yourself active, you keep your blood pressure good, and your diet good. You can, again, a lot of these things are preventable. Okay. Vasectomy, we already talked about. Removal of the vas deferens. We actually cut the vas deferens and then ligate or sew the both ends, and still there's a 0.01% chance of getting pregnant. We are, again, examples of life finds a way. Here's the prostate. If it's enlarged, you could see. Can't pee too well and can't ejaculate too well either. So the two things that could be a problem. In order for me to diagnose and look at that stuff, I could do TURP, which is a transurethral. Let me say that again. Transurethral resection of the prostate. So I can cut away some of the prostate through the urethra of my patient's penis, right there. And yes, we put you under for that because that's an adventure all in itself. Here is also the vas deferens. Is very quick, something I should have got years ago. I remember threatening it, but any of y'all Catholic? They don't believe in this. And my wife and my family and my whole family, they don't believe in stuff like that. And so that's why I got tons of kids. But you know what? You know what's the greatest thing? Abstinence. Just don't be there. That's what I learned. But it doesn't matter with my wife. She'll just adopt one. And that's what she did last year. Now let's look at all this. We went through all of this except for IVF, in vitro fertilization. That's when they call test tube babies, and that's not really an accurate thing. But just know that remove the egg, remove the sperm, and then we put them together and then put it back into mommy or the surrogate, either one. LMP, last menstrual period. ED, very common, erectile dysfunction. Gang, number one cause of ED is diabetic hypertension. So if any of your male patients, and also for female, it ruins the sexual experience, especially if you're diabetic or you have hypertension. It ruins the experience as well for your female patients. But for male, it's super, super obvious, ED. And they're craving for the happy blue pill called Viagra, but that's not the problem. You got to get to the problem. Okay, I hear my kids. All right, I got to wrap it all up. Okay, gang. So sorry to cut you guys off, but I see 1, 2, 3, 4. And thank you for putting up with me and putting up with the last minute cancellation. I'll get it out to you in a day or two on what's going to go on, if we're going to keep on just doing stuff online, on how I'm going to resolve my my childcare issues at this time. Alrighty, so gang, sorry, no Q&A today. Baby's on the loose. So I got all 4 of you. All 4 of you get credit. And please shoot me a email if you have any questions or any comments. I gotta skedaddle. All right. So everyone have a good one, and please look at your announcements, especially in the next couple of days. All right, and I'll hopefully see you on campus next week. Okay, I'm gonna log off now.